Okay, so we're going to move on to the next set of slides. This slide and the next few slides are talking about the different valves in the heart. The first valves we're going to talk about are the atrioventricular valves, and that's what the AV stands for. So it's kind of a long set of words, so let me write that down. Atrioventricular valves. They basically are going to open when the blood pressure in the ventricles is low, and when they do open, they allow the blood to flow down from the atria into the ventricles. Remember, the atria are the chambers at the top, and the ventricles are the larger chambers at the bottom. So in the picture you can see it's zooming in on one of the AV valves. One's right here. There's another one over here, and both of those AV valves are between the atria at the top and the ventricles at the bottom. Again, between the atria at the top and the ventricles at the bottom. They're going to be closed normally, just like the one on the left here, where it's closed. Okay, and the blood, in this case, is going to be in the ventricles, okay, down at the bottom, and then it's going to be pumping out of the heart. Once that happens, the ventricular pressure is lower, and then the AV valves open. So over here on this side, we've got a picture of what it looks like when the AV valves are open. So remember, the blood has just left the ventricles, so the ventricles are now empty. So we're going to refill them, and we're going to send the blood from the atria down into the ventricles, from the atria down into the ventricles. You can see a couple different things in this larger blown up picture. You can see the valves themselves. Remember, the names of them are the tricuspid and the bicuspid. Another name for the bicuspid is the mitral valve. They are attached to the papillary muscles, and those papillary muscles are shown right here. Okay. The papillary muscles are continuous with the myocardium, with the heart muscle itself. And they're attached via all of these little stringy looking things, and all of these stringy looking things are called chordae tendineae. And basically the papillary muscles contract and relax. When they contract or relax, they push or pull on these chordae tendineae because everything's attached, and it either opens or closes that valve. This is just a picture showing the AV valves closed. When the AV valve is closed, then the blood cannot move up and back in the heart. So just kind of remembering what the heart kind of looks like. I'm just going to go ahead and draw just a rough sketch over here. Okay. We've got the atria at the top, and then the ventricles at the bottom. And you've got right across the middle the valves. So when the valves are closed, like this one is right here on the left-hand side, all of the blood that's down here in the ventricle cannot move back upwards. It cannot get back up here into the atria, where the only place it can go is out through the aorta if it's on the left-hand side, or out through the pulmonary arteries if it's on the right-hand side. So it's going to be closed when we want the blood to leave the heart. And then just like this picture on the top here, over here on the right-hand side, you can see that it's open, and that would allow the blood to move down. If we had it open and then we wanted to pump the blood out of the heart, it would leak backwards. So we want it to stay closed when we want to pump the blood around the outside of the heart, so that the blood can hit that closed door but stay down in the ventricle down here so that it all exits. So let's just write a couple of those things down. Right? So the AV valves, remember that stands for atrioventricular. When they close, it's going to be to prevent any backflow of blood. And that's going to allow the blood to leave the heart through the pulmonary artery or the aorta. Okay. The semilunar valves are going to be the two in the middle kind of area, and those are going to be leading into the aorta. So the aortic semilunar is going to be leading right into the aorta from the left side of the heart. And then the pulmonary semilunar is going to be leading from the right ventricle up and out the pulmonary arteries. And the blood, remember, is going to be going to the lungs. When you say pulmonary, that always means lungs. And then the aortic semilunar is sending blood out the aorta, which goes around to all the different body parts. So these particular ones, these semilunar valves, are going to be open when the ventricles contract. So they're going to be open when there's ventricular contraction. And they're going to close with ventricular relaxation so that that blood can refill the ventricle. All right, the cardiac cycle is next. With the cardiac cycle, we're going to talk about basically the heartbeat itself. So the first thing that happens is we're going to fill the top part of the heart. So the relaxed atria, which are the two top chambers, are going to fill. So you can see that that's going to be this area at the top first, okay? And they're going to fill up with blood from either the lungs or the body. The second thing that's going to happen is we want to move this blood then through the heart. The blood is going to be constantly moving through the heart. The heart is just kind of like a chamber or like a passageway. It's pumping the blood to the next place. So the next thing that's going to happen is those atria, both the left and the right, are going to contract at the same time. So big fancy word for same time is simultaneously. Okay, so at the same time. Okay. The next thing that's going to happen is when those atria contract, we want that blood to move down into the ventricles, just like in this picture over here on the right. We want the blood to move down into the ventricles. So the AV valves are going to be open when it's moving down, and then they're going to snap shut, and now all the blood is going to be in the ventricles. So the next thing that we want is we want the blood to continue to move. Well, the next place we want it to move is out of the heart. So we need it to move up and out through that aorta and through that pulmonary artery. So now we're going to have our filled ventricles contracting. And they're going to do this at the same time. So I'm just going to abbreviate that, simultaneously. There's a name for that, and we'll come back to this when we talk more about blood pressure, but the name for when the ventricles contract is called systole. Systole. It looks like systole, but they pronounce it systole. Okay. Remember that those AV valves snap shut so that the blood doesn't move back up into the atria. We want it to move all out of the heart through those two vessels in the middle, the aorta and the pulmonary artery. Okay. And then the last thing that's going to happen is the ventricles are then going to contract so that we can kind of repeat everything all over again. So the ventricles are going to relax. We'll talk more about this word in a future set of notes, but that is called diastole. So the relaxed part is called diastole. Okay. And then again, the blood's going to be then moving up and out of the heart, up and out of the heart through all of the different blood vessels. All right, coronary circulation. I was talking about this a little bit way back in the beginning of the first video. Basically, coronary, every time you hear the word coronary, it refers to the heart, okay, just like pulmonary refers to the lungs. So in coronary circulation, there's going to be circulation to the heart itself. So we're going to get blood supply to the heart, because remember, the heart is made of muscle. And every single type of tissue, every single cell in our body needs oxygen. So the heart needs oxygen too. So while it's pumping blood out to the rest of the body or out to the lungs, in order for it to stay alive, to keep pumping, the tissue itself needs oxygen and needs nutrients and needs amino acids and glucose and all that good stuff. So the heart tissue, remember, is mostly muscle, so we call that myocardium. And we're going to send blood there through special arteries called coronary arteries. Anytime you hear coronary, you want to think heart. Okay. So the heart muscle itself is always constantly beating, so it's going to need lots of nutrients, oxygen and glucose, right, for ATP. Once it pumps blood out, it's going to go through the coronary arteries. So remember, blood leaves the heart to go to the body through the aorta. Let me just switch colors real quick. Okay. And so we're sending blood out. This is all oxygenated blood. And so the blood's going to be going out to the head and to the shoulders and to the neck and then down into the trunk of your body and your legs. But the heart needs blood. So how does the heart get blood? Well, there's these little branches that come off and they go right out to itself. So they basically go out, but then they kind of just cover here the heart itself. So you can see them all here. These are all called coronary arteries. And they squiggle off and divide into smaller and smaller branches called arterioles and capillaries. And they feed the heart muscle on the outside of the heart. They feed the muscle on the outside of the heart. So all this tissue out here, okay, all the heart muscle is going to be getting oxygenated blood. It's going to be getting glucose sent right from that aorta. And this is the problem, is if there's a blockage, okay, if there's a blockage in any of these little arteries that are feeding the heart, that's what leads to a heart attack. We're going to talk more about heart attacks later, but let's say there's a little blockage right here, okay, in this area of the coronary artery, then the blood is going to go, but then it's going to get stuck. And there's not going to be any blood that gets to this area. So all that tissue, all that muscle would start to die. It doesn't have oxygen, it doesn't have glucose, the cells are going to die. And that could lead to a heart attack if it's a large enough section. All right, cardiac conduction is going to be more about the heartbeat. You did a little video clip of this and you labeled your diagram already, so you should have a diagram label that looks just like this. The cardiac conduction system is basically a system, they call it a nodal system because there's nodes, which means like little bundles of nerves. Okay, it's a nodal system and it's going to control how the heart basically contracts. So it's going to control and coordinate the contraction of the heart muscle. So just a quick review, the first little piece is going to be this SA node, stands for sinoatrial node. It gets a message from the brain to stimulate an impulse, and that impulse allows for a contraction. That impulse spreads over to the left atria and down the right atria. It goes to the next little section. The next node is called the AV node. It's between the atria and the ventricle, so it's called the atrioventricular node. And that has a series of nerve fibers that also run along and from it, right down the septum. Remember, the septum is the middle of the heart. That's called the AV bundle. And then there's a left branch and a right branch. So we've got the left branch going to the left side, the right branch going to the right side. They go up all through the myocardium, and they go up all through the myocardium on both sides. And then it branches off into smaller and smaller branches, and ththose are called Purkinje fibers. And then what happens is that message basically just travels, starting way up here, remember, in the atria, down to the atrioventricular node, down into the ventricles, and then all throughout the ventricles, down into the ventricles and all throughout the ventricles. And remember, those are called Purkinje fibers, named after a doctor. And that just spreads the message for that entire heart then to contract. So just one more review, the parts of the conduction system. The SA, remember, stands for sinoatrial node. That's what they call the pacemaker of the heart. If it's not working, then your heart doesn't beat properly, and you might have to have an artificial pacemaker put in, and that would be a separate area. They usually put it kind of near your clavicle and your shoulder, and then it has wires that attach to your heart. And basically, if your brain isn't telling your heart to pump and to contract, then the pacemaker will send a little shock to get your heart beating like in a normal rhythm. So the SA node is a cluster of cells. They're autorhythmic. That means they beat on their own. Auto means self. It initiates and it sets the pace for your heartbeat. Typically, a normal heartbeat resting is anywhere from 70 to 80 beats per minute. Sometimes it's a little bit lower if you're just sitting or sleeping. If you're Younger, it's usually a little bit lower too. Then we go to the AV node. Remember, that's right here in between the atria and the ventricle. Then we go down into the AV bundle, which is in the septum. And there's a left bundle going down the left side, a right bundle going down the right side, and then it spreads out. And that spreading out where it branches out are called Purkinje fibers. All right, so first thing remember that happens is the SA node fires. That's at the top in the atria, so the atria contract. It sends the message to the next node, which is the AV node. There's a slight, split-second delay, and then the AV node fires. So that delay allows the atria to contract first, send the blood down into the ventricles, and then the second part is then the AV node fires, and it sends the message on into the ventricles, and then that lets the ventricles contract a split second later. So you get that atria contracting at the top, sending the blood down, and then the ventricles contracting next, and then sending the blood out of the heart. And it just gives enough time for the valves to open and close properly and for the timing to be right. The couple of hormones that we're going to talk about in this unit, we usually try to talk about hormones in every couple units because we don't do an entire unit on hormones, are epinephrine and acetylcholine. You'll hear them talk about epinephrine a lot in the different doctor shows. They'll usually call it epi. And you might have heard about it with an EpiPen. An EpiPen is what somebody might use if they were having an allergic reaction. So epinephrine is what that stands for. It increases the heart rate and the force of contraction. Usually what happens then is your heart starts to beat a little bit faster. And the name for that is called tachycardia. And you learned tachy way back at the beginning of the semester when we talked about prefixes. The prefix tachy means fast. So this is basically a fast heart rate. And so in the doctor shows, they'll say he's tachy. He's tachy at 90, which is saying that he's got 90 beats per minute. He's tachy at 100. He's got 100 beats per minute. Remember, normal is about 70 to 80. The next hormone is called acetylcholine. Acetylcholine is going to do the exact opposite. It's going to decrease the heart rate. And remember, the fancy name for slow is Brady. So they call it bradycardia. And this means slow heart rate. And in the doctor shows, they'll say he's bradying down. Bradying down means basically his heartbeat is dropping way too low, and they're usually very worried that your heart is just going to stop. You have receptors in all kinds of different places in your body that are going to kind of tell your brain whether to make your heart beat faster or make your heart beat slower. So these receptors are going to detect changes. Remember, this is your nervous system. It's detecting all kinds of changes in your environment. They might detect a change in your blood pressure. That's your BP. If your blood pressure is too low or too high, they're going to send a message to your brain. And it's going to tell the brain to react appropriately. And there's a cardiovascular center in the brain. The brain then decides whether it should make your heart beat faster or make your heart beat slower. All right, heart rate continued. What else is heart rate affected by? Well, heart rate could be affected by hormones. Some hormones that affect it are thyroid hormones. There's one called norepinephrine that also affects it. Ion concentrations. If you have too high or too low of ion concentrations, that can affect your heart rate. Some ions that are super important in muscle contraction and nerve messages are sodium, that's your Na, potassium, that's K, and calcium, which is Ca. And in fact, one of the things they use for a lethal injection, if somebody was sentenced to death and they got a lethal injection, is actually potassium. This is the K. They give a high dose of potassium in an IV, and that actually can stop the heart. Another thing that can affect your heart rate is age, gender, male versus female, your fitness level, so like your size, emotions, so stress, fear, anger, and actually body temperature can affect it, okay? Other things that can affect heart rate are drugs. So, for example, like a stimulant would increase your heart rate, and then a depressant would decrease it. And then last but not least, when you watch like Grey's Anatomy or Chicago Med, they talk about vital signs that they would take in the field, like a paramedic or as soon as you get to the hospital. And then they constantly taking your vital signs the whole time you're in the hospital. So that's going to be your pulse, which is basically your heart rate, your blood pressure, so we'll abbreviate that BP, your body temperature, and your respiratory rate. Your respiratory rate is like how many breaths per minute, basically. Another thing they do now is they actually do a pulse ox, which is the amount of oxygen in your blood. And so that's the little thing you see sometimes they'll put on your finger. It's like a little clip that stays attached to your finger. All right, cardiovascular problems are next. So the biggest one that we talk about is a heart attack. And the fancy word for heart attack is myocardial infarction. In the doctor shows, they're going to say MI. So they'll say something like, we've got a possible MI. And that basically just means heart attack. So if they say MI, they mean heart attack. So what is a heart attack? It's basically going to be pain. And that's usually due to a total blockage in a coronary artery. If you have a total blockage of a coronary artery, you're going to have a lack of oxygen to those heart cells and a lack of nutrients. Remember things like glucose, amino acids, fatty acids, and glycerol. So going back to the coronary arteries, remember those are the ones that branch off the aorta and feed the heart muscle itself. Remember, this is on the outside of the heart. I'm telling you right now, there is a question on your test that's going to ask, what is a heart attack? How does it happen? And what's so bad about that? And you're going to say there's a blockage. Where is that blockage? The blockage is in a coronary artery. So you want to make sure you say coronary artery. Okay. That blockage of the coronary artery leads to a lack of oxygen and nutrients to the heart cells. So those are called heart muscle. Remember, myocardial cells. All right, what happens? Well, the cells die. And if those cells die, then you're going to have a loss of function. And remember, those heart muscle cells, their purpose, their sole job is to contract. So you get a loss of contraction in that portion of heart muscle. And basically, your heart isn't beating as well. It's not pushing the blood out as well. And so then the rest of your body is going to be affected because it's not going to be getting any oxygen or nutrients either. So if you look at this picture again, you had that blockage, okay? The blockage was happening right here, okay? I'll do it in yellow. Anything below that blockage is not going to be getting oxygen. And so those cells that are below it, okay, that are going to be fed by that artery are not going to be fed. It's like a road closure. If the road is closed where it's yellow, okay, and if the road is closed right there, then you're not going to have blood flowing past it. The road is closed. No oxygen, no glucose, and all that brown area, those cells are going to die. Those cells are going to not get their nutrients, not get their glucose, not make their ATP, not get their oxygen. They're going to die. And that portion of the heart is going to also die. And basically it's going to stop contracting. And then therefore the person may die. This particular coronary artery right here, let me change my color real quick. Okay, the one that branches off on this side, okay, is oftentimes called, it's really thick. It's a little bit thicker than this one. And it's called the widowmaker, because if you get a blockage in this area, it feeds such a large portion of the heart that oftentimes those are going to be the deadly heart attacks, and then therefore the person's going to die and leave a widow. Look at the picture real quick one more time. What's causing that blockage? It's going to be something called plaque. Plaque is a combination of like fats and cholesterol and some different substances, and basically it just builds up. It's very sticky. It sticks to the walls of your blood vessels, and as it builds up more and more, it starts to narrow that area. Usually you have a little bit of pain if this happens, and then you might go see your doctor. If you don't, and they don't open that back up through some different procedures we'll talk about later, then it keeps building up and it keeps building up, and then when it totally covers it and it totally blocks it, that's that total blockage we talked about, and that's where it leads to a heart attack. All right, so what are some symptoms ahead of time? Well, one of the symptoms ahead of time is called angina. Angina is basically going to be chest pain. And if you have chest pain, usually you want to see a doctor right away. Why are you having chest pain? Well, it could be many reasons. With angina, the heart itself is getting usually not enough oxygen. So it's getting too little oxygen and nutrients, okay? And that's usually because of low blood flow. Why would you have low blood flow? We'll take a look at the picture. If you have a little bit of buildup in that artery, that coronary artery that's feeding the heart, in this one they're showing it down here at the bottom on the other side of the heart, then the blood's going to be flowing slower, and you're going to get less oxygen, less nutrients, and the heart's not going to be able to beat as well. It's still going to get some, okay? Oftentimes, you're going to feel better a little bit, so sometimes the pain goes away, and then you're like, oh, I'm okay. So the pain may go away after maybe even just like 15 minutes, sometimes with rest, it's because your heart needs then to pump less, or sometimes maybe you take like an aspirin, so medication, and aspirin thins the blood, but you still want to go see a doctor because they're going to do a test to look at your blood vessels and see, are there any that have any blockages? Are there any that are too narrow? Okay. All right. Next thing is congestive heart failure. Basically, the heart is just worn out, and it's just not beating as well anymore. So if it is worn out, it's going to pump really inefficiently, which basically means not as good. It's not as strong of a heartbeat. It's not pumping the blood out as fast. And then your whole body is going to be getting less oxygen. Reasons for it, one is hypertension. Hypertension is a fancy word for high blood pressure. It could be just heart disease where your heart is been damaged. It could be due to age, and it could be due to a heart attack where some of your heart muscle actually did die, and so the rest of your heart is not working as well. If the left side of your heart fails, it's pumping blood out to your body, but remember it's getting blood from your lungs, and so it's not going to pump blood out as well to your body. The blood gets backed up on the left side of the heart, and then remember that blood was coming from your lungs, and so you're going to get swelling in the lung vessels. Okay. If the right side of the heart fails, then remember that blood going to the right side of the heart, okay, and it's not pumping blood out as well to the lungs. Well, where did that blood come from? It's coming from the body. So if this isn't pumping out, it's filling up, and it's going to back up, back up, back up, and so you're going to get swelling in the body. Next up is heart transplant. Heart transplants are a little less common than the kidney transplants that we talked about, but more common than a lung transplant. They basically remove everything but the atrial walls. They're going to take somebody's heart who has passed away, so a cadaver heart, and they're going to put it into the person who needs it, and they're going to reconnect all the arteries and all of the veins and then restart the heart. While you're getting your heart taken out, you're on what they call a heart-lung bypass, which is a machine that basically does the work of the heart and the lungs for you because your heart isn't connected to your lungs or to your body's circulatory system. This is kind of an interesting one, and if you ever have a baby or you're somebody that has a baby, they might have to worry about the baby having a different blood type with them. Blood types we'll talk about in a little bit, but Rh negative is one type of blood type. If the mom is Rh negative and the fetus is Rh positive, that's when you might have this hemolytic disease of the newborn. What happens is their blood will mix when the baby is born. because you have some tearing of the vaginal canal during the birth and the baby. It's making its way down. And so the blood you might have a little bit of blood mixed between the mom and the baby. It's not a big deal in the first pregnancy, because by the time they have the baby and the baby's mom and the blood are mixing, the mom's immune system doesn't have time to make anything right away. It takes several days to make antibodies. So baby's born, but the mom has been exposed to that Rh positive blood that they don't recognize. And so as the mom gets exposed to this Rh positive blood, her body starts to make antibodies. What are antibodies? Well, antibodies fight against like bad guys. So germs, things that aren't supposed to be there, things that your body doesn't recognize. So in this case, it's making antibodies against Rh positive because it doesn't recognize those. Well, then when the mom gets pregnant with a second baby, she already has those antibodies. They just stay in your system, sort of like a memory card. And if there's any mixing of the blood, those antibodies in the second pregnancy or the third pregnancy or whatever, if that baby is also Rh positive again, and there's mixing of the blood again, her antibodies are going to fight against and start to damage the blood cells of the baby. And so what they do is they test the mom. If she's Rh negative and the father is Rh positive, there's a possibility the baby could be positive. And with any second and third pregnancies, they give a shot called Rogam. And that shot then is going to basically binds to the cells, and basically it prevents the mom's body from being able to attack it. All right, leukemia is next. Leukemia is going to be a blood disease, and it's of the white blood cells. So you'll learn that leuc and leukocyte, that prefix leuko, means white blood cells. So acute leukemia is what you're mostly hearing about when you hear about leukemia, and it's basically too many white blood cells. So it's like uncontrolled growth of the white blood cells, okay? And they're going to grow too fast, and they're going to be abnormal sometimes. They're not going to have like normal functioning. Normally you'd think this shouldn't be that big of a deal because white blood cells actually attack bacteria and viruses. So they're part of our immune system. So they do a good job for us. They do a good thing. And you would think that having extra would just make you extra healthy. But the problem is that if you have too many of one, your body's trying to maintain homeostasis. So it's going to crowd out all of the other blood cells. So it's going to crowd out the normal bone marrow cells. And those normal bone marrow cells normally make red blood cells and platelets. And so it's going to prevent the production of those other types of blood cells. So it causes not only too many white blood cells, but it's going to cause you to make less red blood cells and less platelets. And so you're going to have too many of one thing and not enough of the other. Chemotherapy and things like that are going to be things that they'll do to treat a leukemia. Radiation isn't really effective because it's all over in your blood. A bone marrow transplant's another thing they can do because the bone marrow is what's making your white blood cells, and so they can reset your bone marrow with a healthy person's. They can oftentimes then get rid of that abnormal production. Chronic leukemia is something that actually people live with for a very long time. It's very slow growing, and they usually can treat this as it happens. It's not as dangerous to have chronic leukemia. It's more easily treated. All right, we mentioned bone marrow transplants. I'm just going to talk real quick about that. It's an intravenous transfer, so that's what IV stands for, intravenous. Remember, that means inside the veins. Okay, and they're going to give somebody who's sick healthy bone marrow. It's got to be a match, so we'll talk a little bit about that in just a second. But they're going to give somebody healthy matching bone marrow. So it's basically like resetting your bone marrow system. So first thing they're going to do is they're actually going to usually give really strong doses of like chemotherapy or radiation, and it destroys your bone marrow. But that's the person who is sick. So they have unhealthy bone marrow. So they're going to get rid of all my bone marrow that is causing me to have whatever disease I might have, whether it's leukemia or sickle cell anemia, any disease that usually involves the blood, because the bone marrow makes the blood. So we're going to destroy the patient's bone marrow because their bone marrow is bad. It's not working properly. But they're going to be in isolation because you're not going to be making any white blood cells. You're going to be having a much higher chance of getting sick. So usually in isolation, people have to like suit up to come see you, and you're usually in the hospital. Once they destroy enough of your bone marrow, they're going to give you a new infusion of a healthy person's bone marrow. It's got to be a match so that your body doesn't reject it. And then that bone marrow, that new bone marrow, is going to reset and kind of plant new seeds, and it's going to then divide and go through mitosis and make all kinds of new bone marrow, which is now healthy. And if that works, then you've basically reset your bone marrow system with healthy bone marrow, and it gets rid of the disease. So how do they do it? Well, they're going to usually take the marrow from a healthy person. There's a couple places they usually do. It's usually in the pelvis, and they use a needle. It's a pretty thick needle because it has to have like a wide opening, and they basically suck out the bone marrow. It's fairly painful for the donor, the person who's giving the bone marrow, so they usually put them under anesthesia. But the pain is just like when you're done, you're just going to be sore for a while. So you can actually be on a bone marrow list. When you go and donate blood, they'll ask you sometimes if you want to be on the bone marrow list. If you are a match, then they would call you, and you might be able to donate bone marrow to somebody. All right, the last one for today is aneurysm. It's our last like heart issue. An aneurysm is in this picture is basically a ballooning or like a bulging of the artery, and so that's going to be abnormal. We don't want the arteries to look like that. We want it to be nice and strong. So it's abnormal bulging. Sometimes they'll call it ballooning of an artery wall. The problem with it is it's usually because the artery is getting weakened, and the artery has muscle in the sides of it. We're going to do another lecture on arteries, veins, and capillaries, but right now, just know that the artery has muscle in it, and that muscle weakens. And if that muscle weakens, then the ballooning will happen, and we want to be careful because that could then burst. So you're under a much higher risk of it bursting. So if somebody is a smoker, or has certain diseases, they might be more worried about this. This can happen randomly, just like bad luck, and you wouldn't know it. It's very dangerous because you can bleed out very quickly. If your aorta, which is that really strong one right from the heart, ever has aneurysm and you burst, you have like 4 minutes before you would bleed out. So that one is likely fatal. But if it's a small aneurysm, like in the brain, it can lead to some problems, and then they would want to do surgery right away. If it's an aneurysm somewhere else, it can lead to like internal bleeding, and they would want to find that and stop it right away. So if you have some risk factors, they might do some screening of your aorta and different blood vessels that are more likely to burst because they're under higher pressure, and that's people who've maybe smoked or who had heart disease in the past. All right, so the next one that we'll do, the next video I'll do is probably going to be on arteries, veins, and capillaries, and blood flow. And then I'll do a short one on that. And then the last one will be on the diagnostic tests, which is the rest of this particular PowerPoint. And so look for those to come sometime in the next week.